All right, so now we're actually going to talk about something a little closer to psychiatry, which is delirium and psychosis, as we phase out to the more psychiatric aspects of our lectures. This one's really important because it ties into a lot of overlapping pathophys between delirium and psychosis, and it works right in between our last lecture which involved consciousness, attention, and awareness, and our next lecture, which is substance abuse and addiction. And so let's start with our learning objectives, which you can pause to review further. And really interesting, the history of, I guess, schizophrenia and psychosis and whatever you want to call it. Um, so, of course, originally we have Hippocrates, who was the first figure on record to really talk about madness as a brain-based condition rather than demonic possession, which was more common at the time. And then to fast forward, really quickly to more modern times, like around the 18th or 19th century, we have two guys, Philippe Pinel and Jean-Étienne Esquirol, who basically like defined what delirium means and differentiated that from mania and psychosis. So delirium, these were French guys. They called them délire or something like that. And the mania was actually manie sans délire or something like that. I'm probably butchering it. Can't speak French. But the latter, of course, alluded more to mania. And so these things were kind of seen as like overlapping before these guys came around. And then by 1900s, um, a very famous neurologist and neuroscientist, Carl Wernicke, he proposed basically a theory that kind of broke down how psychosis can maybe look like a disconnection syndrome of some kind. And the thought was that it was between, there was a disconnection of the cortical areas that led to, thought disorders. And this was called subjunction theory. Which we won't go into too much. More famously, Bleuler and in 1911 coined the term schizophrenia, which was around 1911, and schizophrenia is defined by the splitting of psychic unity, meaning a disconnection between affect, thought, and perception, which was also kind of sort of alludes to Wernicke's idea that schizophrenia or psychosis could be some kind of disconnection syndrome. And then by the time of Freud, uh, he described psychosis a little differently. He basically described it as more of an id, oriented disorder, and specifically that the ego was reabsorbed into the id, and that psychosis was defined by a lack of reality testing, given the fact that the ego function that typically allowed um, uh, basically differentiating between internal and external stimuli was extinguished because the ego was reabsorbed in the id, which actually has some neuroscientific underpinnings there. And then by 1913, we have Carl Jaspers. He wrote his own textbook that separated delusion from confusion. Um, with the former being more of a psychotic distortion of meaning, and the latter being an organic disruption of clarity. And he also emphasized focusing on phenomenology for these syndromes here. And then by the discovery of the EEG by Hans Berger in 1929, there were some objective correlates of consciousness that were found that we sort of alluded to in a previous lecture on consciousness. And then by the 1940s, Lennox and Gibbs linked basically diffuse slowing of found in the EEG to metabolic encephalopathies, which we now see as like triphasic and global slowing. And then most recently, the kind of sort of more modern neuroscience here, we started incorporating a lot of psychiatric conditions into unifying theories. So we're going to go through a lot of these in this lecture, but one of them is by Rodolfo Linares in 1999 called lamocortical dysrhythmia, which we'll talk about in detail. But it basically proposed that a lot of neuropsychiatric disorders share the same abnormal coupling between the thalamus and the cortex. And then, of course, we can't talk about neuroscience without mentioning Carl Friston, and of course, his predictive coding ideas involving active inference and delusion formation. And then Mark Solms and Jack Panksepp, who invented effective neuroscience and neuropsychoanalysis, reframed Freud's initial ego as an integrative predictive system that regulates these underlying lower brainstem centers of emotion. And then finally, my favorite, probably just to show my own bias, my favorite theory here is called the triple network model, which is basically the aberrant salience model of schizophrenia, which was initially proposed by Menon in 2011, which stated that basically all psychopathology, at least to some extent, revolves around the coordination between three networks, which is the salience network, default mode network, and central executive network. Um, and so cultural perspectives on psychosis, because this is very important. When we talk about reality testing, which I guess was originally brought up by Freud, um, we have to think about whose reality it is, as reality is commonly scaffolded by one's cultural context. And so, basically, the brain's networks just constructs what makes the most sense internally to the individual, but it's the society that provides the external validation of what counts as real. And so to give some example of, differences around the world, um, spiritual possession in trance states are really common across Africa, Asia, and along the Americas. The possessed person can often enter a sort of dissociative or hallucinatory state. This can be mediated by rhythmic drumming, fasting, sensory overloads. Of course, psychedelic sacraments can be used as well to trigger these altered states, and the mechanism may be possibly modulated by thalamocortical synchrony. And so these states may also involve transient network level differences as well, and mystical experiences in a lot of cultures which are defined by, basically the subjective experience of boundary dissolution between the self and the world, can also share a lot of features with psychosis, derealization, or even mania sometimes. And that the difference here is that they occur willingly and typically in structured, culturally confined contexts that are deeply integrated within their own cultural symbolic systems. And typically people who go through these states are well-trained individuals. They have strong ego boundaries, and they already have these cultural interpretive frameworks provided by cultural religious traditions to give some sort of a safety net in terms of context. And then in modern neuroscience, as we've discussed before, these mystical states are likely mediated by some transient suppression of the default mode network and different network dynamics. Uh, and also, since we're talking about psychosis, hallucinations, it's kind of interesting to see how auditory hallucinations might differ across different cultures. In 2015, there's this anthropologist named Tanya Luhrmann, and she published a study that compared 20 patients with schizophrenia from different cultures. And although there's a lot of similarities between all of them, it's kind of interesting that a sample that she had in California described people having voices that were more intrusive and obviously distressing. But there's a sample in South India that was more likely to describe them as providing useful guidance, while another sample in West Africa described these auditory hallucinations as being more likely to describe to be morally good, and even very casually just powerful voices that demanded their respect, but not in a way that was distressing to them at all. So this all kind of makes you wonder if this Western society might be able to even incorporate its own framework for these states. And it makes you kind of wonder, maybe ask yourself, like, what would that context look like? Um, and so, this is a little more about reality testing. Again, initially introduced by Freud. And it was basically a process to distinguish between inner and outer worlds and feelings. And Freud proposed that developmentally, initially, when we're infants, we don't really differentiate between these states too much. And we don't really differentiate between desire and reality. And so both are basically initially fused. And then over time, as the ego develops, it basically emerges as a mediator between the internal drive, which is called the id, and the external world, which is typically the superego. And then he proposed this idea that psychopathology ranges between psychosis, which is id driven, to neurosis, which is more superego driven. Um, and so, so of course, if you lose the ego, then the id takes over, and that's psychosis. And if you have an overly rigid ego, then that's when the superego basically is more predominant. And either way, you distort internal conflicts and all the psychoanalytic stuff. But reality testing has stuck around with us, and we even use it today. It's a common phrase that we say in psychiatry as well, along with like things like thought disorder, which is sort of along the same line. And in the modern day, more from a more neuroscientific perspective, the ego is seen more as a predictive model of the self. Neuroanatomically is seen very similarly to the DMN. And the reality testing, so to speak, would mean that, when we're doing that, we're really testing the integrity of one's predictive coding. And so this predictive process, as we've talked about before, is influenced by active inference, which is the bottom-up kind of sensory, hypothesis testing. And when we have too little active inference, then the world becomes vague and confusing and looks a lot like delirium. And when there's too much top-down contextual expectations, or we hold our prior predictive models too tightly, and those beliefs can actually be stronger than the evidence that we're getting. And so this could lead to delusions and hallucinations, also known as, of course, psychosis. And so, basically, reality testing is really important because it's sort of a meeting point between the mind and the brain, which is the ego's effort to keep the predictive model calibrated to external feedback. And we'll talk a little more about these three networks on the bottom of your screen here. But here's just some descriptions that might be helpful. But we'll talk about it in a little bit more. But yeah, basically as we know, the DMN is the internal narrative. Central Executive Network is executive modulation, and the salience network actually helps mediate the self-world boundary detection, meaning it can direct attention either inward or outward. And since we're going to talk about delirium and psychosis, initially I actually thought that this lecture could be about altered mental status, because if we meet somebody for the first time and we know absolutely nothing about them, how do we know that an older patient isn't just confused and delirious versus maybe having, a mostly lifelong primary psychotic disorder? And so this is just, I thought it could be a helpful slide going through some of the differences between delirium and psychosis, but you can review that on your own time. And so we'll discuss the functional neuroanatomy here. And so the thalamus, again, this is building up on what we learned in our last lecture. The thalamus, of course, integrates not only sensations, but it also activates or helps the ARAS or the ascending reticular activating system activate our attentiveness and our awareness. And you can't really be aware without being alert. And as you would imagine, the thalamus is a huge synchronizer of the brain, emitting all these specific frequencies that we catch onto the EEG. And whenever that synchrony from that rhythm breaks down, it leads to a fluctuating level of awareness given the breakdown of the ascending reticular activating system. And that's thought to possibly contribute to delirium. Um, and as we've mentioned in the last lecture, the conscious perception of something really depends on the coherence between the thalamus and the cortex, specifically when those oscillations are in the gamma range, which is about 30 to 80 hertz. And in encephalopathic states, perception is characterized by diffuse slowing on the EEG. So that's like in the theta delta range. And we see this diffuse slowing as being pathognomonic of encephalopathic states, um, which, again, not to be redundant, is secondary to this thalamocortical desynchrony. And so when this effect is localized and all the time, it actually may underlie something completely different. So if the thalamocortical synchrony is diffuse, that's thought to underlie delirium. But if it is localized in the thalamus, then it can actually lead to psychosis. Um, and so, we've seen this in EEG studies, and there's many papers on this feature of abnormal gamma synchronization in psychotic states. And these are found particularly in like the auditory and frontal networks, which we also see correlate in fMRI studies with reduced thalamic prefrontal connectivity. And so these findings led to a proposed theory called the thalamocortical dysrhythmia theory, which proposed that dysregulation of inhibitory input can lead to hyperpolarization of thalamic relay neurons, which typically lead to the generation of these like low frequency sort of theta, 4 to 7 hertz oscillations that can lead to a paradoxical hyperexcitability in disinhibited neighboring cortical areas, which can be either diffuse in delirium or localized in psychosis. And so this is the theory, yeah, thalamocortical dysrhythmia. It was proposed by Linus and Stiriad. And it was like, I think they found it using EEG and MEG studies in like between like 99 and 2006. These consistently showed a pathological shift from the normal high frequencies of these thalamic oscillations, which are usually in the beta gamma, usually gamma range, to persistent low frequency like theta delta rhythms in these thalamocortical circuits, which were a common feature shared in a whole wide range of neuropsychiatric conditions, actually. It's kind of interesting that it wasn't just in schizophrenia. And I think delirium was also, of course, in this as well, but it was actually also found in tinnitus and chronic pain, which I don't know what to do much about. But facts are facts, I guess. And it was also in Parkinson's disease and depression. And so we're not quite sure what to make of that, or at least I'm not. But we do know that the normal function of these thalamocortical loops are pretty dynamic. They alternate between high frequencies in wakefulness and low frequencies in sleep, which we learned in our sleep lecture earlier. And the reticular nucleus of the thalamus usually helps in providing the inhibitory regulation, which shapes the rhythms of cortical activity. And so this input to when this input to the thalamus is dysfunctional, then it becomes polarized, so it's more positive, and it leads to the thalamus to become basically at a relatively lower frequency, hence lower than that beta gamma range that it typically is in. And the cortical regions actually have the opposite thing. It actually leads them to be at a higher frequency. And this difference between a lower frequency thalamus and a higher frequency cortex is called became to be known as the edge effect, which leads to a breakdown between internal prediction states, which are typically sometimes gated by the cortex to the thalamus, and the external verification that's typically gated from the thalamus to the cortex. And so that edge is the mismatch between the two. And so again, the thalamus kind of gates conscious perception, as we talked about in our last lecture. And if that happens globally, it's delirium, which is something that's experienced as fragmented consciousness and it's kind of chaotic. But if it's localized, it leads to basically the rest of the brain kind of adapting to that weird state, and the cortex starts to believe um, things more easily because it's not verified by the active inference that's fed in by the thalamus. And so, yeah, it's interesting because the diffuse slowing that we see on EEG is very common with delirium. But we don't actually see, to my knowledge, any of these differences with schizophrenia. So, I don't recommend putting patients with schizophrenia under EEG if we don't think that they're actually, having a seizure or having any other reason to do it. So this is just, a general overview of the nodes that are involved in each of the main networks that are involved in or thought to be involved in psychopathology. And this idea, this triple network model of psychopathology, is a unifying theory for just about all neuropsychiatric disorders, at least from a mostly cortical standpoint. Um, and I know, we've probably talked about this many times by now, but the default mode network was originally found because it's our default state. We basically put people in a PET scan and just ask them to do nothing. And these are the nodes that kind of lit up in the middle here that we see: the subgenual anterior cingulate cortex, posterior cingulate cortex, medial PFC, precuneus, and the angular gyrus. And hyperactivity of this network is usually associated with mood disorders. And because it was found, because that's just our default state, it used to be known as the task off network. Um, and then the opposite, which is the task on network, is the central executive network. It's also sometimes called the frontal parietal network as well. It's composed of the following nodes like anterior cingulate cortex, dorsolateral PFC, and basically the idea here is that and the parietal cortex as well. But the idea here is that this is involved in executing movement, goal-directed behaviors, while also having, if you have, if a depressed brain has a hyperactive default mode network, it will also have a low active executive network, which is why behavior activation is hard, but it's also therapeutic, hopefully over time with depression. This is also found, this dynamic is also found in psychosis by a little bit, but what's most important with psychotic disorders is actually the salience network, which has a lot of shared, I guess, circuitry with the reward system, which we're going to talk about in our next lecture with addiction. But it's all dopaminergic. And so the nodes here are anterior cingulate cortex, which of course is involved in all three of the networks, the anterior insula, nucleus accumbens, ventral striatum, so midbrain stuff, the amygdala and the hippocampus, which the amygdala and hippocampus technically feed into all these networks as well, even though I didn't write it that way. But the salience, if the default mode network is the off state, the executive network is the on state. I would say the salience network is somewhat of the switch. And so if the switch is broken, as these old school, mesolimbic theories of schizophrenia might imply, then the switching between directing attention inward versus outward is off. And when that's off, we might misattribute salient stimuli as being, basically coming in from the opposite side of our Markov blanket. So basically, you can hear your own voice and you think it's coming from the outside. You hear other people's voices and you might think it's coming from the inside or other stimuli. You might be paying attention a little too much to stimuli that isn't typically salience just because your dopamine is like, misrepresenting it as such. And all of this could eventually lead to a more of a psychotic subjective experience. But this isn't really, mutually exclusive to thalamocortical dysrhythmia model of psychosis. It's just, another perspective of it. And here you go. Yep, which is what I wrote right there in the bottom. And this whole interplay between these three networks are probably off in delirium and psychosis, but this is just some extra background information in case you want to review it in your own time. And one second. And then here's actually some more along the same vein. Just another way to view these networks in different terms. And so, when I think of these different theories for schizophrenia, like the thalamocortical dysrhythmia model, or the aberrant salience model, or Carl Friston's issues with predictive coding, it really feels like that age-old, I should have put a picture of this story of like, having many blind men feeling different parts of a big elephant. And, the guy who like touches the tail feels like, oh, this is a snake. Or like the guy who touches like a foot is like, oh, this is the trunk of a tree. And in reality, we're all kind of wrong. But at the same, but it's all really the same thing. We're just seeing it from different perspectives and whatnot. And I guess like a more recent theory is all the way at the bottom here is this idea that maybe psychosis is secondary to dysfunction of glutamatergic or NMDA receptors. And that's mostly just from seeing how delirium and psychosis can be replicated, possibly by ketamine or PCP. You can say the same thing along the lines of like, well, maybe then it's just dopamine because we block dopamine with antipsychotics, but maybe it's also serotonin because we block serotonin with antipsychotics that are just slightly newer. And so these are all probably tackling probably the same thing if we're seeing the same benefit. But it's kind of, I guess, like what's exciting is seeing how all these different theories for psychosis might be able to all make sense together. And one thing that's kind of interesting is that there's this kind of overlap between schizophrenia and psychosis and OCD. And there's always these loops that are involved in just about all psychiatric issues. We're going to talk about these a little more, these specific loops, these CSTC loops in our OCD lecture. But they might also be dysfunctional in schizophrenia. And of course, we're talking about cortical, striatal, thalamocortical loops. And these are just thick tracks that connect, distant nodes to each other. And so if the nodes aren't working, and it could be because of the node, it could be because of the track, but when the track, between the thalamus and the cortex is off, then we can actually, it can actually lead to different clinical manifestations, which you can go through here, which are all related to psychosis. But what I think is also interesting is that there's a some shared structures that are not working well in OCD as well. Might explain the overlap. All right, so now we got to the clinical stuff. Let's start with actually diagnosing schizophrenia, at least by using the DSM-5. You can pause the screen and review the specific criteria that I screenshotted here. But basically, psychotic disorders are defined as a syndrome that's a collection of both positive and negative symptoms. The positive symptoms of schizophrenia are typically like delusions, hallucinations, things that add to one's experience, good or bad. And the negative symptoms are usually things that take away. So, like, think about like apathy and loss of drive, diminished, emotional expression, kind of the classic schizophrenia, flat affect, and things like that. And these collections of symptoms or the syndrome has to occur for at least 6 months. If it's less, it's probably like a schizophreniform disorder, but I've never actually seen that diagnosed, but technically it's in the DSM-5. And what's interesting is that over here, schizoaffective disorder is basically schizophrenia plus a mood disorder. Rather, that's a depression subtype or a manic or bipolar subtype. And it's kind of interesting to kind of connect that to this triple network model of schizophrenia or psychopathology, because, like I said before, you sometimes you can't really separate these different psychiatric conditions from each other because they actually might occur together, and we're going to see a lot of this overlapping mechanisms in our next lecture as well for addiction. Um, and I think that's basically it for here. Psychosis it can happen outside of schizophrenia and probably even more commonly happens outside of schizophrenia. We're gonna talk about all kinds of ways to be psychotic, like eventually with the neuro lectures, like autoimmune encephalitis. Neurodegenerative disorders can cause it, TBI can cause it. And so DSM-5 is super simplistic and kind of dumb. And so they just like lump it all together. And it seems like in a very like non-important way. They just call it psychotic disorder due to another medical condition. But it's up to us to really define the root of that so we can try to treat the underlying cause. Um, Neuropsychological testing is kind of interesting. Well, usually always, but specifically with schizophrenia, and also I guess delirium. But I don't think anybody would be doing psychological testing on a delirious patient. Um, but basically with schizophrenia, you like a lot of psychiatric issues, you have a dysexecutive syndrome. So attention it kind of takes a toll. Working memory does, executive function, processing speed, all that pretty much takes a toll. You're not really as good at planning for the future. Your memory just might. It's not that it's bad. It's just that it's your attention is probably elsewhere. But that sort of like pseudo dementia picture is actually a historical thing with schizophrenia because the first name for schizophrenia before Bleuler named it, it was called dementia precox. And so it was seen as like an early onset dementia because people just seemed like they couldn't remember anything. They were demented. Um, and that might just actually not be the case, but it's really, really hard to know. But you can go through these tests if you like, but just left it here. And like I said before, when I first made this lecture, I actually thought that this could be like a good like neuro lecture for altered mental status. I think neuropsychiatrists, this entire specialty sometimes feels like an altered mental status specialist. And I think that this is still relevant for people who might be delirious or psychotic, and we don't know yet. And so we work them up, at least initially, the same. If we're confident that it's a first break, then we might still start the workup the same with some differences that we'll talk about. But with any workup, we're going to start with the history. Um, So you got to ask yourself, is the patient awake and oriented? Delirium can be defined as a very simple syndrome of just two things, which is just orientation and attention. So are they attending to the exam and are they oriented? Also, very commonly, do they have sleep-wake or circadian rhythm disturbances, which from our sleep lecture, we should know that we should always ask our patients about sleep. And it's also important to determine like what's the level of their arousal. Again, how's their attention? And on physical exam, we want to check for any other signs of like infection or comorbid medical things that might be contributing to their mental status. So like meningitic signs like nuchorigidity, wounds, indwelling devices, jaundice, dehydration, edema, or is their skin blue? Is their skin yellow? Questions like that. On our neuro exam, we want to, well, one, make sure that they don't have a stroke. And so focal deficits, speech fluency, comprehension, those things are really important. Also, is it possible they could have like a more Parkinson's? Are they Parkinsonized? Like, is there rigidity or tremor? Because it could be primary Parkinson's, or do they have a primary psychotic disorder? And they were treated with it, and these are extrapyramidal signs. Maybe there's also a medical thing going on, like are they having like toxic metabolic type myoclonus, like serotonin syndrome, hyperreflexia, maybe it's metabolic, hyporeflexia, how's their gait, can they walk? These are all important questions which I guess are kind of common sense. I'm sorry about that. But of course, we got to see their vitals. Is there any autonomic instability that would make you concerned of like a malignant catatonia or something like that? Or maybe they're hypoxic, and that's a definite good reason to be confused. So we want to order also like the whole gamut of basic labs, and basically everything you can think of, like finger stick first, which should have already been done, but just to confirm CBC, CMP, electrolytes, thyroid, B12, folate, UA, definitely a UA, and with reflex to culture, urine drug screen, blood culture, inflammatory markers, liver panel, ammonia, the whole gamut. And then once all of that stuff is out of the way, and depending on the acuity, if it's like super acute, if there's like a head strike or something like that, then of course they should have already gotten a non-con head CT. They probably should have a very low threshold to get one anyway, just to make sure there isn't like a big structural thing in their brain or just screen for like a stroke, possibly if the time seems like it fits. But then once all that stuff is out of the way, now we consider the big stuff. Like do they need an MRI? Well, if they can sit for an MRI, that would be great. If there's any suspicion for like a limbic encephalitis of some kind, or that would be great. Suspicion, any focal deficits, is there like demyelination and autoimmune history of some kind? Any reason for press? Those are all reasons to get an MRI. Depending on how they present, if there's any suspicion for a seizure, there's a very low threshold for an EEG. But also, like we said before, like an EEG is not just for seizures. Even the diffuse slowing, triphasics, that would be helpful. It'd be helpful to know that they're not seizing and that they have more of a delirious looking EEG that we talked about with the global thalamocortical dysynchrony and all that. Now, if there's any infectious signs like fever, headache, stiff neck, immunosuppression, then an LP is definitely needed. Also for trying if they have an APE-2 score above, 2 or 4, which we're going to talk about in this own lecture too, then we want to work them up for autoimmune encephalitis as well. Um, so I have all these things written on the notes under the slide, but some CSF studies that we commonly get is the basic stuff, which is cell count, glucose, protein, culture, viral panel, an autoimmune, antibody panel. Usually we send that to Mayo, like the ENC2 panel, but also, if we're not tapping them, we can get an ENS2 panel sent to Mayo too for autoimmune markers. And if there's any cancer consideration, then maybe we should just pan scan them in case this is a perineoplastic situation. Um, but yeah, so if the patient is has new onset psychiatric or psychotic symptoms, and then we're going to have a lower threshold to work up for autoimmune encephalitis, given the timing. But this gets really, really dicey when it comes to first break, and so we're going to talk more about that in its own lecture. So if this seems more like delirium, then the treatment is somewhat supportive. We want to make sure that they're medically stable. We want to make sure that, whatever the underlying medical thing that's driving the delirium that's going on is being treated, because treating the underlying issue is going to be basically the mainstay of treatment here. But then, we also want to see if there's anything that we're doing to contribute to it. So we want to go through, their medications that they're getting, stop any offending agents like anticholinergics, benzos, opioids. Maybe they're just getting a lot of meds. These are all things to keep in mind that we always tend to do a pretty good job at. And then we also, the thing that's the common dot phrase that we use is that we want to optimize the environment with delirium precautions. And so what does that mean? It usually means frequent orientation, like, having a large clock in front of their bed, a calendar in their room. Hopefully, they have good stimuli to know what's day and night and have their circadian rhythm checked. So, a bed that's facing the window, if possible, would be great. Avoid any unnecessary nighttime vitals if that's possible at all. You can start melatonin at night to help that sleep cycle. You can also, ensure they have all the stuff that they need, their glasses, their dentures, their hearing aids. Make sure that in the daytime they're as active as they can be in the hospital. So like get, out of bed, out to the chair, PTOT, sitting up with meals. And maybe most importantly, it would be really, really nice if at all possible, for them to have some familiar faces, family, friends, and loved ones, to visit during visiting hours for them. Sundowning is really difficult. A lot of patients that are delirious do tend to act out at night. If they're doing something that puts them in danger, we really try to avoid restraints, as this typically actually only worsens the delirium. Um, we also try to avoid using medications unless they're really doing some dangerous behaviors. And so only as like a last resort do we resort to these meds. And it's, since these patients tend to be on the older side, these are like baby doses if we need it at all. Like the Haldol should be less than a milligram, like probably zero point 0.5. Honestly, I don't even like Haldol that much because it's, too much of you don't want to cause an older person EPS. Maybe some like low grade Seroquel, like 12.5 to 25 milligrams. This one is also safe for patients who you might think are Parkinsonized. Um, I guess just because we do it so often, Zyprexa is really common. Five might be a little too much for older people. Maybe I'm a little bit on the conservative side, but 2.5 should be good. We usually, when it comes to giving this to patients, giving the illusion of choice sometimes it is a little tricky but helpful. And so sometimes I ask them if they want to, take it by mouth or we can give the injection. But I really hate to do that. If they're in the ICU, especially if they're so agitated that they need to be in the ICU just for agitation, then Precedex is definitely needed. And if there's no contraindication, Depakote is a very easy, and especially if they have IV access, Depakote is a very easy one to give. Now for psychosis, completely different ball game here. This is like if they're really, psychotic, of course, agitation meds are going to be just PRNs. Um, Usually, I guess, like in Bellevue, people get 5 and 2 all the time, like 5 milligrams of Haldol and 2 milligrams of Ativan. It's probably not the best, to be honest with you. And maybe this is like a controversial territory here, but they can probably be fine on just like 5 of Zyprexa or something like that. That comes orally or by IM if needed. We really try to avoid first generation antipsychotics due to the risk of EPS. You don't want to, if somebody's already miserable in the hospital, you don't want to give them like an acute dystonic crisis. That's not going to help. And so, these can still happen with atypicals, especially risperidone, but they're a little less likely, especially with Zyprexa, although it could definitely happen. Seroquel, again, is a little more safe. You just have to be careful with people who are older due to the anticholinergic aspect. So you should make sure that they are in a safe place. They're not standing. You get them lying down in a bed and try to monitor their vitals, and make sure that they're also eating, drinking, and really, if they're acting out, we have to ask ourselves, why are they acting out first? Is there something that's like very easy that we can address just verbally? These meds should really be a last resort, only if basically somebody else or the patient is in danger. And then, if we need to start them on a standing antipsychotic, then that's definitely something that you should get psychiatry involved. They're really good at that. That's literally their bread and butter. So they should be good there. And they can also troubleshoot, any other factors that might be contributing to agitation as well. Now, another thing that could also happen is that they might not be psychotic forever. This might be secondary psychosis. Maybe they just did a bunch of meth and now they're psychotic and they just need to metabolize for a while. And we just have to make sure that they're not psychosis temporarily from some other reason. Like, is this like post-ictal psychosis? Is there a medication that's causing it, like steroids or something like that? And are they just like sleep deprived, or is it autoimmune? So we really should do a pretty thorough workup to make sure that this stuff is out of the way. If somebody has been on at least two antipsychotics and it's still not working, then that's usually when we start considering them treatment-resistant psychosis and start considering clozapine. Which has a pretty severe, set of monitoring need. And so that should be started by psychiatry. Um, and just some other things too. If the psychosis is related to dementia with Lewy bodies, or even Parkinson's disease, there's only three antipsychotics that could be used for these. The most common is Seroquel. It's typically first line just out of convenience and accessibility, not really because it's the best. And it's usually dosed like super baby dose, like 12.5 to 25 at night. Clozapine can also be very helpful. That would be probably second line, I'd say. Again, more out of accessibility, because the third line one is mostly because it's like so expensive, it's like impossible to get, is pimavanserin, which is actually like primarily indicated for this reason, but it's too expensive to use. Um, and Yeah, and neurology can also help with that too. Keep in mind that clozapine, Seroquel, and um, high doses of Zyprexa can all lower the seizure threshold, especially clozapine. So if somebody has any concern for seizures, well, we should be very judicious with that use. And if possible, we might even prefer something more like risperidone or Abilify that's not associated with lowering the seizure threshold significantly. And then while first generation antipsychotics tend to be more potent D2 blockers and run the risk of EPS. Second gens, of course, is more of a risk of metabolic syndromes, which, of course, if you have a patient that has had a stroke or dementia, and you give them something that worsens their cardiometabolic stuff, you're going to increase their risk factors for future strokes. So definitely be careful with that. And then lastly, I know this is a lot of random stuff here, but we really want to avoid, if somebody's agitated, we want to avoid giving IM Zyprexa and benzos together because of a known risk of respiratory depression. People can even die from that, so we definitely want to avoid that. And then in terms of therapy for psychosis, it's not common from a very analytical standpoint. Usually, supportive psychotherapy is usually the mainstay. But there's a lot of and for interesting reasons. Basically, from an analytic standpoint, people who have psychosis are thought to have poor ego function and ego boundaries, and it's thought that they don't tolerate higher level intensive therapies. And so, supportive therapy is usually the mainstay because that's what we think they could best tolerate. But there's some really cool, novel therapies coming out for people, especially if people are stably, outpatient psychotic. And so Michael Garrett, that's actually works here at NYU, wrote this book called Psychotherapy for Psychosis. He was initially a psychoanalyst that went on to learn CBT and developed CBT for psychosis, which is really interesting in terms of like gently kind of shaking up people's delusions, in terms of and kind of encourage cognitive restructuring for delusions and things like that. Metacognitive training is something that could help with like self-reflection and cognitive biases with the goal of improving insight. Family psychoeducation is extremely important, mo not even so much for the patient themselves, but more for the to make sure that the support knows, like what to expect and to reduce their stress preemptively, and hopefully ensure that they continue to support the patient, especially with their adherence to meds. This intervention, this family psychoeducation, has actually been shown to reduce the relapse of psychoses by 30 to 40%. So it's definitely helpful. And then, we can also do certain behavioral interventions like emphasizing structure and routine, encouraging social engagement, and occupational therapy as well, because that structure is thought to be a good holding environment to make sure that people can function better in society. And that's also been shown to keep them out of the hospital for longer, by kind of re-engaging, these salience and executive networks. People are more likely to direct their attention to the right things, meaning, not the internal voices and illusions, but rather the outer tasks and, more responsibility and societal needs and things like that. So that's very helpful. And here's just a summary of most of the things that we talked about for psychosis and delirium. And yeah, I mean, you can review this on your own time. Just to sum up, I would say that while delirium is a disorder of arousal and attention, and it's more of a thalamocortical failure, while psychosis is really a disorder of reality content, while the attention is intact. So it's more of a failure between the salience and default mode network interplay, to keep it simple. But to go for our next lecture, we're actually going to talk about addiction, which is going to touch more on a older aspect related to schizophrenia, which is aberrant mesolimbic function. So yeah, definitely stick around for that.